Try again, try again.
Can you hear me?
Yes.
Echo?
Yes, but it is echoing, yeah.
Can you hear me?
Yes.
How is not? We are not seeing this here because it's connected. Hello? Hello? Can you see? Hello? Hello?
That's okay. It's okay.
Sorry for that.
I think we can hear now.
Okay. So being identified as a major public health challenge, this next only to climate change because of the number of impact on not only just the mortality and morbidity, but also like the poverty, pushing for people to get off poverty, and especially the major diseases that we know about. The process of resistance is a major challenge, and economic loss has been identified as a major global challenge. So there have been a lot of global effort, like since 2001, for example, beginning with the WHO's global strategy to contain the antimicrobial resistance. There have been resolutions, multiple resolutions. Then, even the UN General Assembly identifying the importance of this issue, coming up with a commitment at the global level, bringing all the countries, member states to commit to actions. This was followed by a series of reports and systems in place, especially led by WHO and other organizations like the World Animal Organization and the Food and Agriculture Organization, because this is a multi-sectoral issue. So we had multiple reports. Then WHO came up also with a GLASS system, which is basically trying to help countries to sort of work on data to take decisions around antibiotic resistance, antibiotic consumption. So earlier it began with resistance, but then it also expanded to include antibiotic consumption because it's a key determinant of resistance pattern. Why India? So India is, as I said, is the largest consumer of antibiotics in the world. And India, it's 28 states and 8 union territories. There's a lot of diversity, and there is also a diversity in terms of regulatory frameworks and regulations. For example, we do not have a single approving agency for antibiotics or any drugs for that matter in India. We have like 28 plus 129 approving agencies in India, which makes it very complicated. Back around 20 years back, when India moved to develop its national health mission to really work around the Millennium Development Goals that time, and then the Sustainable Development Goals, especially focusing on infectious diseases, maternal and child health. Try to focus on certain states called the high focus states, which have the highest burden of infectious diseases, maternal and child health. And also these states were also having some of the most poorest socioeconomic situation in the country. So there are a lot of diversity, there's a lot of differences. And private sector is the major provider of healthcare in the country. Even though it's not insurance based, it's still the largest provider because of accessibility and all other issues. And then also the providers are mostly constant in the urban areas. So there is a fertile ground for a lot of inappropriate use, given the diversity, because given the fact that a huge proportion of our providers are not trained formally. So there's a potential for a large inappropriate use of antibiotics in the country. So this is important to address this, to address the resistance issues. There may be like very proximate factors which determine antibiotic inappropriate use, which may be like the prescription patterns, which may be like the care-seeking behavior of patients. But in this work, we try to largely focus on the bigger factors, the macro factors, the socioeconomic factors, the progress that have happened in the country in the last 20, 30 years, with all the opening up of the market, large influx of international marketing, international pharmaceutical companies coming into the picture, increase in the production of medicine, and also increased access to healthcare and increase in the coverage by the private sector in terms of healthcare delivery. We had, right after independence, we had a rule and act in place which regulates medicine sales and production and purchase, but they were like not strictly implemented in that sense. And as I said, health is a state subject, so states had a lot of prerogatives in deciding what to do and what not to do. But India also moved along with the Global Action Plan, had its own National Action Plan in 2017. And there were some regulations in between which were brought in to at least restrict some of those antibiotic sales, especially related to tuberculosis and some of the third generation antibiotics. So in this dissertation, we tried to do 4 different pieces, which all sync together to sort of understand the Indian landscape of antibiotic use. So we first started with a cross-sectional 1-year data to see like what is it on a typical year, what is it about antibiotic consumption in India. Then we moved on to a longitudinal analytical study trying to see like what has happened over the last 10 years in terms of antibiotic consumption. Then we try to see like what are the factors which are driving the antibiotic consumption in India. And then we also, in the context of the states moving ahead with the action plans, we decided to do a case study to see like how much data are used in these policy-making processes. So I will spend a few minutes in these slides because we had to use some standard methods to sort of assess the utilization of antibiotics. So there is a WHO center in Norway which actually come together and classify the drugs, including antibiotics. So they have a system called the Anatomical, Therapeutical, and Therapeutic Chemical Classification System, or the ATC system, which we used to classify our drugs. So in that, you can see that J is representing the anti-infectives, and in the anti-infectives, we have J01, which is the antibacterials, and we use this group as our, the group that we studied. And we know that there are different classes of antibiotics, and essentially there are 5 levels of classification in this system, which for each particular antibiotic, we have a code, and you can see some numbers there. So these numbers are the measures that we actually used to calculate how much antibiotic is used, because it's a standardized measure, because we know that antibiotics come in different forms, different pack sizes in different countries. So we need a standard measure that's called the defined daily dose that we actually use to measure. That's actually an average assumed dose. It's not something that you will never get an ampicillin at that dose on a daily basis, but it's an average use. So we use this system, this metrics, to measure antibiotics. And for adjusting for population, we also calculated for per 1,000 population per day. So this is the basic unit that we used. For the regarding the data source, primarily we used a sales data, which is a national representative data coming across the country. So it's a huge data set, which for each product in the market, you get to know like what is the strength and what is the pack size and how much of it have been sold every month. So we use this information, and really this was one of the major portion or major work that we had during this dissertation. We tried to create a database using this data system, clubbing it with the WHO system of classification and measurement. We tried to measure like what is a standard measure of antibiotic use in the country. So it was like really creating database for the last 10 years from this raw data. And we had a lot of challenges here because we had to find out some of those measures and units from different sources because some of the data were missing. So it's a huge data. So we had to actually work on it a lot. Then with this data and the measure, we try to understand what is the level of appropriateness. So one of the basic criteria that is globally used is the WHO AWARE system. So AWARE stands for Access, Watch, and Reserve. So it's basically a consensus by clinicians and experts. Okay, these are some of the drugs which can be safely used. Access molecules like green. Then watch. Okay, we have to be careful in using this. You have to reduce the use of watch molecules. And reserve should be really reserved for critically ill patients. So this is a standard unit that is used, standard measurement that is used globally to see like how appropriate is antibiotic use. And there are some targets. For example, access share should be more than 60%. Access to watch ratio should be more than 1 in a general or outpatient setting. Beyond this, we also try to look into 3 specific things for the Indian context because this mattered for India. For example, the fixed dose combinations is a particular situation in India. India has a very high proportion of fixed dose combination of antibiotics. You're clubbing different molecules and selling it out. So this is a challenge. So we want to see like what proportion is this FTC. Then we also try to see against the national list of essential medicine, which is based on the WHO list, because national list actually puts some checkpoint in terms of the rationale of certain antibiotics, and also like put some checkpoints on the cost of the medicine. So we want to see like how it is. And as I mentioned in the beginning, the approval, there are different levels of approval. The central approval, which is considered more, more based on the more expert opinions and data, we want to see like how much of it is approved versus not approved. So going ahead, the first paper was literally trying to see like on a particular year how it is, how much of it antibiotics consumed and how much is the appropriateness level. So from 85 antibiotic molecules, we had around 10,000 products of antibiotics in India in a typical year. So this is a huge market, huge challenge in terms of quality assurance. Using some of the key results, I'm not saying every result here, I'm just sharing the highlights. So we can see that in terms of using the measurement of DDD, there is a particular value because you see different proportions when it compared to the brands of the product versus defined daily doses. So there's an advantage of using this standard measure. That's what we find from the results. And we find that at least 20% of the molecules contain discouraged FTCs. So the molecules which are, WHO says these are discouraged, they should not be used. Watch category, which should be minimally used or restrictedly used, is around 53%. So there is a level of inappropriate use of antibiotics, which is very evident from these initial results. And our consumption rate was around 5,000 million doses, and it comes to around 10 defined daily doses per 1,000 people per day. So roughly, you can say that 1% of the Indian population consume antibiotics daily. And azithromycin is the most consumed, like in many countries, including the US. Again, the watch molecules, which are mostly broad spectrum, was the largely consumed group, which is concerned. And regarding the regulatory framework, we see that even in the 22% of the approved products, the centrally approved products contain WHO discouraged formulations. And among all the fixed dose combination, 50% had discouraged formulations, which is really a challenge. So the key conclusions, we have a low consumption, per capita consumption of antibiotics, even though we have the highest volume in the world. We have a high consumption rate of broad spectrum antibiotics, which is not good. We have a high consumption rate of FDCs discouraged by WHO, which means they are inappropriate. Non-NLEM formulations, which means like they are not under price restrictions, there's a large share. And there is a lot of unapproved formulations. Move ahead with the second paper, which is basically trying to see what has happened over the years. So again, we use the same metrics, same comparison, same groupings. Here we also try to compare between the states, try to see what has happened over the years. And we try to compare between the two groups of states, the high focus and non-high focus, see like how much they differed. And also we went ahead and in each of the individual groups, we try to see like how much the states differed. We see that the consumption increased till 2016 and then came down. Access consumption going down and watch consumption going up, which means there's a progressive, inappropriate use of antibiotics. Wide variation across the states. The top states that you see having the lowest consumption, they are all the high focus states, means they are the states with poor socioeconomic status in the society, high infectious disease burden, and relatively poor health systems. Over the years, we try to see like what has happened. we see that the per capita consumption rate increased in 6 states, and some of the states so very sharp decline, for example, in Delhi. And we had some hypothesis on like why this pattern we see. The access group, which is a good group of antibiotics, we know we should have more of access molecules. We see only 2 states showing an increase in the consumption. The watch groups, which should ideally going down, we see only 4 states showing that pattern, that the enough, the less of watch being consumed over years. Discouraged FDC is decreased in 5 states, and one of the states had around 4.5% decrease. Others are very marginal. We find significant difference between the 2 groups of states, statistically significant differences in the median consumption values between these two groups of states. And we also did the analysis within each of the group. We found significant differences between these. Even within the group, we had differences. Key conclusions: there exist wide geographical variations. There is significant temporal variations. Delhi has almost 3 times than that of the most of the high focus states. Antibiotic consumption decreased overall. This is again, we should know that this is a private sector antibiotic consumption, which makes up around 85% of the total consumption in the country. Good thing, there's a reduction in the discouraged FTCs. There's an increase in the use of essential medicines. There's an increase in the use of approved formulations. The question is whether more of these formulations got approved or more of them were, unapproved formulations were taken out, is something which has to be explored. No state had the international global target of 60%, which is to be met by 2023. There is inappropriate use increase, at least in some of the, especially in the high focus states, which is worrying because they are again having poor health infrastructure. The third question was trying to see like how much is the effect of some of the key macro socioeconomic factors on the antibiotic consumption in India. So for this, we did a thorough review of the literature to identify all those factors that have been described in the literature that have an effect on antibiotic use. It varies from behaviors, prescription styles, physician availability, qualification of doctors, climate change, infectious disease pattern. But among all those things, we focused on the economic growth, on the population, government spending on health, women's education as a proxy of social progress, vaccination definitely has been shown to have an impact, and of course, infections to see like to control for the infection. So we try to do a study to adjust for this all the time invariant factors, because we found that, for example, in a state level, the climate change over 10 years may not be significant enough to change the antibiotic use, behaviors and perceptions. So we try to use a method to control for these a lot of confounders and try to see like what is the effect of these key variables on the antibiotic use. As I mentioned, the population, the net state domestic product, the GDP minus depreciation. So we used Reserve Bank of India data and the government documents and the health management system, information system data, and the global burden of disease data to gather these different variables. So what we essentially did is we brought all this data along with our antibiotic consumption data from PharmaTrack and created a panel. So it's basically we created a cross-sectional time series data and did a state level fixed effect study. So to see like control for all the other confounders, what is the effect of all the change in the value of these key variables on the antibiotic consumption. So just to remind, there is a significant difference across the state in antibiotic consumption, which is our outcome measure. And there is also significant difference between states in terms of the input independent variables that we included in our study. So there is significant difference in all those factors that we try to incorporate in our model. So our final model showed that there is a significant effect of per capita GDP, spending on health, girls' tertiary enrollment in the school, and of course, infection rate on the rate of antibiotic use in the country. And we found that per capita GDP, per capita spending on health by the government, and girls' education decrease the antibiotic consumption. So when the education log goes up, the per capita consumption goes down. And of course, as expected, with respiratory tract infection going up, we expect more antibiotic consumption. So the key findings, key conclusions, to translate into a more clear variable, for every 1,000 rupees increase in per capita GDP, that is $12, we find that 10 antibiotic doses per year per 1,000 population decrease. For every $12 per capita spending on health increase, we found 464 doses of antibiotics going down per 1,000 population per year. And per 1% increase in girls' enrollment in school, 46 doses of antibiotics going down. So there's significant impact of these selected measures. Of course, we didn't find significant effect with the vaccination. We use measles vaccination as a measure, and the literature shows that it is better to use some of the other variables like pneumococcal vaccine, but unfortunately, we didn't have data for the last 10 years to include in our model. The final one is on understanding the use of data in decision making, especially with the state action plans. How much data were used in formulating this action plan, and what was the plan to monitor and evaluate the impact of this action. Again, we had a framework. We used the logic model as a basic framework. We assume that when we have this new action plan in place, we are trying to shift the way things are going. We assume that there will be an improved antibiotic use, which leads to reduced antibiotic resistance. And to see that whether this works, we need to have data collected throughout the period. So we used the intrinsic case study approach, because that time when we started the study, there was only one state which had a state action plan, that was the state of Kerala. So we conducted in-depth interviews with key informants who were involved or were related to this plan. And we also reviewed the documents to see that how much emphasis is kept for data. We reviewed, we didn't have much to review except a few, like we had the action plan, we had some reports, we had some government orders which stipulated who constitutes the committee and what's the committee's role and what's the terms of reference, and presentations which are in public domain. We tried to interview some of the key people involved who were leading these efforts, but we had challenges. Then we had around 13 interviews from the public and private sector, representing the professional associations, representing the clinicians, representing people who are from One Health, people who are from public health, and see what do they think about the state action plan. The key findings, again, not going into the details, I have all the slides in the end, if we can go and see those things later on if we need. There is a monitoring and evaluation one table in the whole document, which is essentially just a list of few indicators with no clear definitions, no logic model, and no theory of change. If you see that. Interviews revealed that there is a lack of continuity in governance and leadership. So there was definitely a political leadership, a very good political involvement in the beginning, but later on somehow we lost that continuity. Then there is a neglect at some point in terms of using data for governance and planning. For example, the document shows there is no clarity of indicators. When we talk to the people, the stakeholders have definitely some idea on what needs to be collected, but then there is a lack of clarity. And we also see that from the documents we found, the committees consisted mostly of microbiologists. We didn't see any pharmaceutical science experts or pharmacologists in those committees, which means that there is a more emphasis on microbial resistance data rather than the consumption data. So I think that's a critical observation. So the key conclusions, there is some basic plan for monitoring, but then there is a clear logic model missing. There have been some recommendations later on, but of course, maybe because of the COVID, there is a lack of follow-up. We need to engage the stakeholders more because private sector is a key stakeholder here. We have to move from just communication and consultation, which they feel now, to collaboration and co-production of the entire process. I think this is very important. So these are the 4 different papers. Just to summarize the whole thing from the all 4 papers, the major 3 things that we conclude. India has to strengthen its policies and practices and programs to improve antibiotic use. No doubt, everyone has to do it. But then it has to work on the prescription. It has to work on the regulations. And last week we see that the 1940s Act is being revamped. There is an open, feedback being requested now. But then there are also criticism that it's not again going to the quality that we need. So we have to strengthen the antibiotic stewardship. We have to strengthen the regulatory approval system. We need a single regulator, or there should be more capacity built for the state level regulators to decide on which formulations to go. Because now even one state can produce, approve it, it can be sold anywhere in the country. And as our third paper showed, government should invest more in health to reduce the private sector consumption of antibiotics. Social programs and improvement in health spending is important. But when we do all these things, we need to see that whatever we do, because now I see there's a lot of efforts by different agencies happening, we need to have a rigorous impact evaluation to see like what actually is working, what is not working. For this, we need a very comprehensive monitoring and evaluation system. Of course, there are platforms like the GLASS platform by the WHO. We can use it. India has its own strength because, for example, the CoWIN portal, that many countries are now using is developed by India. So there is a way to bring in technology, information technology, and to collect some of this data and analyze at various levels of decision making, right from the hospitals to the national level, to see like where we are heading to, and compare it with the resistance patterns that is emerging to see like what can be done to improve the antibiotic use so that we can actually have an effect on the resistance pattern. And we have to think about supplementary data, not just the routine data from all these, sales data, but also like other data that emerge from pharmacy shops, because there's a lot of over-the-counter sales of antibiotics. And you can walk into any pharmacy shop in India and get any antibiotic, so that's something which has to change. Third thing, on a global scale, which I believe is that we have to improve the ways and methods by which we measure antibiotic consumption. For example, DDD is a very good measure, but DDD is based on an adult average dose. So countries like India, which have a high percentage of children, are we clearly, measuring the antibiotic consumption with such huge pediatric population? We need to have improved measures, or maybe we use different combination of different measures. Again, DDD is a good measure, but we need a lot of technical expertise to do that, to calculate it, to measure it. It's not easy. We can get it done easily, maybe using developing information technology tools, from the electronic medical records, or even by using the OCR technologies, even from written prescriptions. How can we generate data and calculate the DDDs for decision makers to use it for policy making? I think that's the findings. Our first paper was already published. It's in June. It was covered widely also in the national media. And we also had an opportunity to publish, share some of our findings from the second paper in the WHO meeting in January 2022. So yeah, that's it. But just a story. This is 11 years back. This was my first talk for All India Radio, which is the national broadcaster in India. So the talk was back to an era of no antibiotics. So yeah, I was just asking my wife, can you find this out? She spent a couple of days to find it out. She couldn't find, but then I found it was with me here. So this is an image from that day. They sent us this letter. Yeah, that's it. And thank you, everyone. You can see my mother, my family, my friends, my DrPH colleagues, my family with from my father, my side and my wife's side, my sister and husband, all of us, they have all been supportive. I'm sure this is not the work of a person. Special thanks to Senthil and Haifa, who were like really supportive in helping me with processing that in the early morning. I mean, 4 o'clock for me, but evening for them. So it's like it's a work of a large number of days. Shaffi, I'm not so sure whether he's here. Shaffi was very instrumental in getting the data and meeting with me almost weekly for the first 6 to 8 months. So yeah, so it's a product of support from everyone, and I'm really grateful to my committee who were like really, they stood with me and like it was like a fast process. I would say we could finish this on time. Thank you so much for listening.
Congratulations on such an impressive body of work. I mean, I think it's for everyone can sort of see, this presentation, how much you accomplished in a very short period of time. As you said, you had a bit of an accelerated timeline, but it's really incredible how much you've done and the high quality. So we're going to move to the committee-led discussion. Is Shaffi on? Okay, great. So welcome, Shaffi. I'd like to turn it over to you if that's okay.
Yep. All right. I guess, is everyone able to hear me?
Yeah.
All right. Let me begin with, well, good morning, everyone. I wanted to first thank my co-panelists, Sandro, Peter, and Veronica, for giving me this opportunity to open this discussion. Let me first congratulate Shaffi for this excellent piece of work, and I'm glad that it's come to its fruition. Something that began about 3 years ago. It's really a comprehensive set of work, and I must again compliment him for doing this in a very technically sound way. I mean, using all the latest set of tools that are globally available, whether it is DDT or whatever other tools. And I also wanted to compliment him for the fact that this is one of the most relevant set of piece of work, given that India's, if you look at the clinical delivery of service, India is perhaps one of the most privatized healthcare market in the world. The reason why I say is that because of the fact that almost 70, little over 70% of outpatient care delivery of services happens in the private sector, and about 50 to 54% of the private of the hospitalization cases happen in the private sector. And no wonder that Shaffi has picked up a very relevant theme looking at antibiotic consumption in the private sector. So, it's comprehensive, technically sound. I must also say that it's extremely relevant in the Indian context. Well, so that's having said that, no doubt he has got very sharp results. The results being highlighting the fact that high consumption is observed across broad spectrum antibiotics. And of course, it's also true that when you look at the aware category of antibiotic consumption, watch category antibiotics is in fact consumed more than than compared to the access category antibiotic. I think these are all very key, very sharp results, and I must certainly compliment Shaffi. But having said that, now I have 2 or 3 quick questions and observations to make. Two is related essentially to the techniques, and then one point is about the policy and programmatic issues. Let me first pick up the technical aspect of it. Now, Shaffi, you've talked about the determinants of antibiotic consumption, and I do realize that income is one important source of private sector antibiotic consumption. The other source, in addition to the other factors, is public spending, especially public procurement of medicines across states. Now, it's important to realize that we're looking at 35 countries. India is essentially 35 countries. Now, if you look at Punjab, Delhi, Tamil Nadu, and Kerala, for instance, where per capita consumption is high, almost 3 times more than the income of, let's say, in UP and Bihar. Now, how do you characterize, and how do you, when you build this model, what would you really look at? Although you've looked at this from the point of view of income and per capita expenditure, how do you see, for instance, I saw that some of the results essentially prove that Delhi and Punjab, where there's high consumption, But Kerala and Tamil Nadu, for instance, where there is income is relatively higher, but you also see in states like Delhi, Kerala, and Tamil Nadu, income is not only high, but you also have the situation of the procurement system is extremely efficient, and they relatively tend to spend more than other states. For instance, Punjab is a classic example where the private income is high, but the public sector procurement is not relatively not so comparatively better than the other states that I talked about. How do you reconcile this result? I think that's my first question. The second question is to do with it's a hypothetical question. Now, if you were to get public sector data, what you've looked at currently is the private sector data. If you were to take into account public sector data, what other determinants would you use into your model, and how do you think the results would change dramatically? That's my hypothetical question, which is related into the model. So that's the second question. The third question is more to do with the program and policy level. We know that irrational, inappropriate consumption is high, partly to do with the fact that you have fixed dose combination, which is a major problem in Indian context. Now, even assuming that the central level, with coordination from the state, they're able to control some of the fixed dose combination. But what other programmatic intervention would you recommend at the state level? Because largely the consumption happened at the state level, especially in a state like Kerala, where your public procurement is good, and yet because of high private consumption, what kind of programmatic intervention would you really think through because of this huge imbalance between public and private, especially in states like Kerala? I'll stop there. If needed, maybe I'll come back a little later. I'll stop with those three separate questions. Again, I wanted to compliment Shaffi for this excellent work. Thank you.
Yes.
Okay, thank you. Thank you. Muted. Yeah. For the questions. Yeah. So I think these are like important points that I think we have also discussed during the process of working on these questions. So essentially, the first question was regarding the determinants of antibiotic use, because we see some patterns which are unexpected. For example, states like Kerala and Tamil Nadu, we see lower consumption, while states like Punjab has a higher consumption. But at the same time, we know that Kerala and Tamil Nadu has a higher per capita spending on health. I think that itself is sort of explanatory, because I think the more your public health systems are strong, you may have an effect not only on the prescription in the public sector, but it will also impact the way private prescribers prescribe the medicine. And Tamil Nadu has a long history of its own medical service corporation, which is like centralized procurement, standardized quality assured procurement by the state government, and distributing it even at the primary care level. So that actually made the medicines available in the public sector. Probably that impacted the private sector consumption. Now, to understand this, as you rightly said, we need to have the public sector data, which was a big challenge, because private sector, at least from the market point of view, it was important for companies to have that. So we have that data, but the private sector, public sector consumption data is really something which we lack. So I believe with the state action plans in place and programs and monitoring evaluation systems in place, we need to have a comprehensive account of the total consumption of the state to see like what is actually happening with some of these policy interventions. Another thing, to just make a point, the Kerala started with an antibiotic stewardship program with the private sector around 2013-14, and it has been documented and has been published their efforts. So our analysis also shows that there is an improvement in the appropriate use of antibiotic in the state of Kerala in multiple indicators. It's access to watch ratio, for example, it's almost doubled. the access consumption increased, wash consumption went down. So there is a need to consistently do these things across other states. That's something which I think is something which can be done at the different levels, different states. The public sector provision of services is not as good as in the state of Punjab, as we discussed about in Kerala, Tamil Nadu, which may explain why there is still a high consumption of antibiotics in states like Punjab. So coming to the second one, the public sector data. When we have the public sector data and we get to know the total consumption, again, we always work on this assumption that 80-85% of the consumption happens in the private sector, which I have put in my dissertation, that this is something which we have to now go back and see whether we are still holding on to some data which we know from maybe 10-15 years back. Things have changed. Probably this proportion might have changed. I'm not saying that we have the data. We have to see that data. And then we also know that there have been some bigger programs, like for example, some states like Delhi, for example, we saw a sharp decline in the consumption, probably to do with the Mohalla clinics that came up like 5 years back. Some states like Tamil Nadu, improved purchase and procurement and distribution to public sector might have impacted their private sector consumption going down. But then I will also add, as you asked, maybe like something to do with improved sanitation, with the heavy focus on improved sanitation measures in the country with the national program by the government of India, and also have better indicators and measures on the effect of vaccination programs in antibiotic use. I think these things will be helpful to have a more comprehensive picture. But we also know we should. One of the limitations to the data of per capita, expenditure by the state government was that it's a big amount of money. But then we want to see like what proportion of it actually goes to medicines purchase. So I think we need to have that data, more granular data, to see like what is actually happening with respect to spending on medicines rather than just spending on health as a whole. The third one on the FDCs, a big challenge. Of course, there are discussions on centralized regulations, central regulator, with also the Drugs and Cosmetic Acts being revised now. I hope that will come through. But then again, I will focus also on the stewardship program and using data to make it clear to the prescribers that's what's happening in terms of inappropriate use of FDCs. I think a peer-supported stewardship program with a real feedback will be helpful in changing the prescription patterns over the years. So,
great. Shaffi, any immediate follow-up?
Well, I'm okay with his observations. Yeah, let's look forward to working more on this, because the challenge really is to get the public sector data and then combine it with the private sector data to see what kind of consumption is happening, and then especially looking at these two, public and private sector, independently, and looking at the results would be even much more interesting and useful for policy and program.
Great. Okay, I'd like to hand it off to Sandra.
Really, well, really, I think you've done. I think you've done terrific work, and I want to say thank you for teaching me about this topic. Actually, I want to thank my fellow community members. There's no area that is something which I knew much about before I joined the community, and I've learned a lot. Thank you all. I have just a couple of questions. I want to start with: are there country models that you think are worth keeping in mind for India? I have a sub-question, but let me ask you a question first. Are there countries that you think are doing things in a way that India could emulate?
okay, I think there are different pieces here that we have talked about in this dissertation. So one of the things is the regulation. So the regulatory framework currently, as I mentioned, is like 36 regulators essentially deciding. So maybe we should have a central regulator, like for example, the FTC in the US is a central regulator in terms of permitting and licensing drugs and formulation. So that is something which can be thought of as a central regulator. Of course, there are various models of centralized procurement. I mean, one of the data that we saw was from China, for example, having a huge public sector provision of services, from what I understand, had a lower per capita consumption. We do not know about the appropriateness level of consumption, but had a lower consumption. So, and some of the states in India have shown that, you know, a centralized procurement, a quality assured procurement can improve even the private sector practices. So maybe some of those things can be, you know, taken into consideration when, especially when the new act is being formulated.
So my sub question to that is, to what extent are political factors in India in the way of solving these things? You know, when I, as I said at the beginning, not that I knew anything about it, I learned through your dissertation, and as an outsider to the topic, you know, you always see the obvious, which is what's very dysfunctional. Like that's obvious. So then you say to yourself, why is that the case? Well, there must be reasons why that's the case. And I imagine that political forces must be a strong part of that. So I wonder if you can comment on that and comment on the political reasons for intransigence in sticking with a system or a non-system that results in the problems you document so well.
I think this is very, very relevant. I think we touched some of these points in our dissertation as well. I think the second and the third chapter, we touched some of these points. So definitely, if you see some of the states which show fairly better in appropriate level of antibiotics, consumption patterns, have a more, you know, political systems which are more of, you know, socially oriented, socialist views in their political stance, and reducing the out-of-pocket expenditure has been a priority for some of these states on health and education right from the beginning. So I think that's a historical background that we should not neglect when we say about the progress that Tamil Nadu and Kerala, states like Tamil Nadu and Kerala has achieved. So there is definitely an aspect to that. Definitely, then we also found an interesting example, but we didn't have much time to work on it. But for example, Delhi had a shift in the way the governance is being done in 5-6 years back. So they had like opened up a large number of clinics called the Mohalla clinics, which are like primary care centers in a city like Delhi, where people found it very difficult to access care. So suddenly you had a large number of such clinics which have been documented to show reduced out-of-pocket expenditure. So they provided drugs free of cost to the patients. So actually you can see a sharpest decline in the private sector consumption, probably because of this. Third one, post 2016, we also see a reduced private sector consumption across the country. It has to do with a large scheme by the government of India rolled out, which was basically the government of India centrally procured certain medicines and generic medicines and supplied across through shops. So that also probably might have had impact. I think these are things which we need to further evaluate more rigorously to see the effect of some of those things in antibiotic consumption.
That's a different question. Shaffi actually prefaced this question. So 8% of doctor services are private sector, 70% of hospitals are private sector. So, but in your dissertation, you talk about incentives for the private sector. Skeptical about incentives for private sector. So I'm actually curious if you cannot speak a bit more frankly about the extent to which the commercial forces are going to be an intransigent force in progress on this issue.
I think this is again an important, very important point. I will also like related to my experience working with the tuberculosis control program, because TB, again, the largest burden, private sector prescription of antibiotics for TB has been a major challenge for India to overcome the resistance and respiratory disease. So incentives, private sector pharmaceutical market, as in any other country, is a very strong determinant of prescription in India. And it has been again and again documented the forces, the power of those forces to influence prescription pattern. I can say, I can relate to my own experience, and you know, when it's not just monetary or financial incentives, it's also non-financial incentives which affect the behavior of prescribers, doctors, and people who sell the medicine without prescription. So,
what was an example of non-financial incentives?
So I don't know, like maybe, you know, taking it's not just the money, it's not the dollars, it's also providing you some perks other than financial incentives, taking you out for some vacations, things like that.
So that happens a lot.
That is a major issue. That's a major issue in the Indian market. So it can start from a small pen, which I think is common everywhere, to flight tickets to Bangkok. So that's a huge structure, incentive structure, which actually reinforces this market. So that is something which regulators have to overcome that power. And we know it's in the US everywhere. It's a huge power that they hold. So that's one thing. But then TV program in India has shown that you have ways to do that. For example, TV program a few years ago started to reimburse the doctors to adhere to the regime, the antibiotic regimen that they should be standardly prescribing. They get their money for selling those antibiotics, but then they are asked to follow certain standard antibiotic regimen. So I think we should be concerned about the appropriate use of antibiotics, all the same time trying to reduce these incentive structures in the market.
Thank you. My last question. So what do you think? I thought your institution did a very nice job of saying here key policy recommendations. What do you think is the top research priority in this area that both advances scholarship but can also nudge the policy recommendations?
I think one of the major challenges that we have currently, as Shaffi also mentioned, we also found out is that the availability of data to make decisions is a critical factor. So we need to have work, research, and scholarship to actually find ways to generate this data in a more, in a way that can be used for policy decisions. Second thing, also to have, as this is a period like I'm seeing a lot of interventions happening everywhere. We need to have a real research-focused way to measure the effect of these interventions to see like what is actually working, what is actually having the best return of investment in terms of before scaling it up across country like India, which is like, you have a huge cost for that, opportunity cost. So before we scale it up, some of those things which we are getting piloted now, we need to have a really research in terms of evaluating some of these pilot programs that are happening.
Thank you.
Thank you, sir.
Thank you very much. Thank you, Shaffi. Really enjoyed the presentation. It was a really excellent presentation. I think you were in a very fortunate situation when I talked to you like 5 days ago, maybe a week ago. You had so many slides, and I tried to say, please, don't overwhelm us. But obviously, you are in a wonderful situation because your work shows how much material, how many results you have created. You were basically in a luxury position to say, let me drop something for my presentation, just focus on the highlights and have a wealth of other information you have here as backup slides. So I know that you have at least 30 to 40 backup slides with so much richness of information that you have created and useful information, including policy implications of recommendations. So congratulations on your presentation as a testimony, I think, to the richness of information and useful evidence that you have created for decision making. I would also like to flag for those not familiar with the topic of antibiotic resistance and how to study antibiotic consumption, a few highlights from my perspective as an expert in this area. First of all, I think what you emphasized in the beginning, that you chose measures that are specifically relevant for India, for me is really a highlight. So you didn't go into that study with kind of like a very narrow view and saying we have already some standard measures of the WHO, let's apply them, we have access to sugar, let's apply them, that's enough for us. You then actually went into that with a very open eyes and saying what's actually policy challenge in India. We spoke about the difficulty of state regulation. So we took into consideration an indicator, which I liked a lot, which was looking at the state approved versus the national approved medicines, which not many studies have done. I think you did this very, very well. Then you took also the topic of fixed dose combinations. A huge challenge for India, particularly in the Indian market, because of the incentive in the Indian market to sell fixed dose combinations. They are not price regulated often. So there is an incentive, we spoke a bit about incentives and commercial incentives, and we took this into consideration very nicely. See visit in Utrecht, for instance, in the January, which caused a lot of attention and also interest by the audience in terms of asking questions, and also I think reviewers who read the lines. So I think that is very, very, very nice. And then in addition, we took the national essential medicine list in India and also compared how many of these medicines are actually used in percentage-wise. So I think we used 3 indicators typical for the Indian context and brought them into the analysis. I think that was something which I value and I think is excellent about the work. Then I also think you communicated very effectively about the highly technical area. And you made the point in the later part of your presentation is that it's hard for us to talk about this because it's a highly technical area, PPD. Who has heard about PPD? Who's familiar with PPD? What it actually means by the area that you focus on is relatively a niche area of public health. When we talk about many economic indicators, public expenditure, most of us are familiar with that. But when you start talking about PPD and with those regulations, I see often many experts just shutting up and saying, that's enough, I don't understand what you're saying. And I think very effectively try to communicate that and also incorporate that in your policy recommendations. So also congratulations, that's not an easy way to do. And I think I see how effectively you did this with the publication of your manuscripts. Communicating with reviewers who might not be familiar or who might have difficult questions for you, and you did this very nicely. So I think all of this shows that you really have an excellent piece of work. I would like to follow up in my questions a little bit of what Sandro already talked about in terms of saying, how do we go from here? And one thing that you mentioned is you would like to bring in the public sector consumption data because you see that is one important gap. Imagine you have now a grant that is given to you as a follow-up. People say, congratulations, Shaffi, here's a follow-up grant. We want you to do more work in this. How would you validate? Tell us a little bit more about your thinking on methodology and validation of the data that you have. Let's say Tamil Nadu gives you their public sector consumption data, which is relatively easy. How would you go on validating that data? How would you go on validating their private consumption data? Tell us a bit more about limitations and advantages of using these different data sources. How would you go on knowing which is qualitative, quality data? How would you go?
Okay, yeah, thank you so much for all your comments and remarks. I hope that we continue this work and we had like a lot of things on the side so that we can continue the work later. So yes, public sector data, getting the data is a challenge, and I have been talking with Shaffi and other colleagues who have been working in this area for a long time to see like how much data are accessible to us to work on this. Some of the states have really good procurement data. Tamil Nadu has a very good procurement data. Kerala has a good procurement data. But then these states are not representative, of their country, which have like fairly good procurement systems in place. So, but then still, there's a need to validate the low consumption in the private sector in these two particular states, for example, and see like whether this adds up when you have the public sector data from the procurement. So, of course, the data that we use is a large data set, much more than the usually used data sets, much bigger than the other usually used data sets. So, but then again, they have a way of sampling which defines and decides the representatives of the data. So, they're documented. It is all documented. We have to have a similar way of bringing data from the procurement system. So the procurement system data will be at the total the state level, showing like what are the antibiotics being prescribed and how much purchased and used. So it also can be converted to the same measures of GDP in a way, and then try to find out the total consumption in the state and see like whether this matches with the expected patterns in other countries, for example, or in other states where we have a different system in this. So I think that's one thing which may be time consuming, but that's something, again, if we start that process, it will be easy for others to follow. So that's something which I will do. Second thing is like, it's also not just about the public spending on health as a whole. Specifically, we actually try to get that data. We don't know that, that we try to get that data. But then, in the budget document to go into that level of fourth or fifth level of budget line item to find that data on like, okay, among the total public spending by government, what goes to purchase, what goes to medicine, and what goes to antibiotics, it's like a really big challenge. At least we can go to the level of drugs quickly. Some of the states we already have the data for the last. But then, I think the video.
No, this is moved.
But then we also need to actually go to that level of data in addition to broadly, trying to compare with public spending on health as such. So I think that's very important. And I would also seriously consider looking into the changes in some of the other indicators which we didn't try, to see like what is happening with some of the interventions. There are like large scale programs in the last few years try to reduce organification and things like that, which actually impacts antibiotics.
Okay, for instance, validated
Yeah, so is it working? Okay, so what I was, so the Tamil Nadu procurement system is like a long-standing system which has been a model for many other states to follow. So they have a very clear procurement systems in plan. It's very transparent, and the data available is also fairly better. So I think that can give us, instead of we can corroborate with the total coming from the same company and what is happening, what is coming to the state government purchase and sales. But I think that is something which can be worked with. The total can be calculated.
Sounds great. One thing which I also wanted to follow up is a bit about the models of the countries. One thing that you haven't mentioned when we were talking about this earlier on is a model that the European Union has followed. And I wanted to give you a chance on talking a little bit about the European Disease Control and Prevention Center, ECDE, and tell us more about their role and how you could see that potentially working for India or maybe not working for India.
Yeah, I think in our second paper, we try to bring a comparison with the European model, and we try to compare the consumption pattern in those countries. The ECDC, which actually bring together all these various, and they had a long history of doing this. Even WHO adopted their methods to create the DDD and the ABC system later on, the EMF, the fraud data system. So, but if you see that there was the latest publication last year, which we tried to bring into our discussions, trying to compare between the group of countries within the Europe, which are integral to the European Union and others, we see the differences there. We also see that I think 13 out of 19 countries in the group have achieved the 60% access target compared to North states in India. So the quality assured procurement system and also the understanding that, for example, when we said India we have only an idea about the private sector consumption. All studies that you see are all private sector consumption. We need to have a comprehensive account of the total consumption. We cannot sit on an assumption that it's 85. I believe it may be the right, but still, especially pediatric formulations and things, is it that we are underestimating some of the consumption that we are observing in India is something which we have to really challenge ourselves to look into. So definitely bring the data systems together, and also like trying to go further into the classes of antibiotics, because the resistance is a major issue in India. We cannot ignore that. So are clinicians really genuinely using some of these antibiotics, or is it an inappropriate use at the community level? Is something which we have to distinguish with more granular data.
Tell me a bit more about the institutional setup. So the European Union has achieved, or European countries have achieved an institution that is at higher level than the national, international nation. It's an institution that sits in Sweden that kind of gather the data and analyzes the data. Is there something comparable in India? Do you foresee an institution would need to be created, would need to be empowered, would need to be, let's say, protected with funds and with responsibilities, or assigned responsibilities by the national government?
I think this is very important, and we have proposed it in my dissertation, that India, and there have been committees after committees recommending this. My shelter committee was the last one recommending that we need a central regulator to begin with. And one of our solutions for this whole issue that India having now is not just a regulator, but also a very high level political commitment at the national level. Because resistance or antibiotic resistance is a major challenge, and the out-of-pocket expenditure and the way that things are going is really a big challenge. So we need to have a centralized system because with the federal system, we need to have the state governments represented in those bodies. We need to have the professional associations buy in, because otherwise the private sector is still so huge, you cannot ignore them. So you have to have the stakeholders on the table and then come up with a plan with some of the responsibilities distributed between the stakeholders. Regulatory framework lies with the government, but then maybe bringing some of these data, which is largely from the private sector, we need to have the private sector on the table to do that. I think a centralized structure like that, and considering and recognizing the federal structure of the country, has to be possible.
Because obviously you have the regulators, which is like equivalent FDA in the United States. You have in the European Union, you have EMA. You obviously have also a national regulation in India that also has powers in the state. But the European CDC is a different entity. It's not the same as the EMA who authorized medicine. It's a different, distinct entity. No? So it would be interesting to see what the development in India are, giving an institution that specific role, no, of monitoring evaluation. Okay, that's great. And then I had a last question in terms of, let me just see, one other question. Last question, speaking. Okay, I hand it over to Peter. When he comes back, I might get back to you.
Thank you.
Peter.
As I said before, yeah, really impressive body of work here. Thank you for this nice presentation. I hope everyone can hear me. Yeah, I'll talk just maybe a little bit about methods. I think just to reflect on what you presented here is a very nice example, I think, for the DrPH students, or for colleagues who are thinking about how to take a really important research question and then approach it from a few different angles with some really important questions, and then choose methods that are really appropriate to answering those questions, and demonstrating expertise in a wide range of methodologies. So I think that the first two papers, and as you talked about, even sort of separate from what's represented in this figure here, even putting together the data set was, I think, a really important contribution to this dissertation. And that data set, I expect and I hope will generate a lot of additional work to answer additional important questions. And then if you can bring in public sector data, it becomes even more powerful. So I think generating the data set as a starting point, and then thinking about a descriptive analysis in the first two papers, really get our heads around sort of what we're seeing here, what's been happening in this country, and then moving to a more sophisticated sort of causal inference framework for thinking this fixed effects approach in paper 3. Those three papers together, I think, produce a very coherent, sort of well-rounded understanding of the situation across this country over the last 10 years. I think that's very powerful, sort of how you brought these different methods together and leveraged this really powerful data set. And then in the fourth paper, we're using a very different qualitative approach to that I think is very complementary to what you showed in the first three papers. I just want to sort of bring that to everyone's attention. I think this is a really great achievement, but also a model for other DrPH students to follow. I think in terms of, it was discussed previously, thinking about the role of recent policy changes. I mean, you talked about in your third paper, when you show kind of your conceptual model and what are the time invariant factors that the model really controls for, the thing that, you know, that you've mentioned that the model doesn't control for is maybe some of these policy changes that are time varying, that are not really captured in the model. And then we talked about this. I think in future work, you could think about putting together an analysis that looks at that. So you talked about in Delhi, the rollout of these clinics. You could think about a way to sort of capture that temporal change in the health system in Delhi and actually analyze it within the same fixed effects framework, which I think could be very powerful. You could think about different ways of trying to capture policy changes and then leverage the data set you've already created to really, you know, I think interrogate and examine maybe what effects those kinds of policy changes have, which I think could be a nice sort of next step just in terms of the investment already made in putting together this data set and this framework. So that's more of a comment. I think in terms of, actually want to follow up on some of the discussion that's been had around institutions. I think you did a very nice job of explaining sort of where power resides at the state level versus national level, regulatory power, you know, the financing power, all these different levers that could be pulled. I actually want to talk more about expertise. And you know, in your fourth paper, you talked about data, the need to generate new data. You also talked about some more, I think, sophisticated evaluation kind of, you know, I wonder from your perspective, where would bottlenecks be in actually generating, you know, do state governments have the kind of expertise, not only to collect data, but to interpret data usefully? What kind of institutions are in place maybe at the state level that would actually be able to generate the kinds of insights that could feed into policy changes, not just monitor sort of indicators over time? Do that kind of that second level, right? So that, I'm gonna ask 3 questions. So number 1 is, what is the current capability, I guess, at the state level to not only collect, I mean, you talked a little bit about they're not collecting the data, but what would it even look like once they collected the data to actually interpret it in a useful way? Number 1. Number 2, what would the role be? I mean, you talked a little bit about the need for national institutions that could, you know, that could sort of leverage political power to have effects. But what about expertise at the national level? I mean, PHFI maybe being sort of playing an important role here, and they probably already are. But if you could talk a little bit about maybe how expertise residing at the state level versus at the national level, and the need for, you know, maybe an ideal way that can be organized. And then my third question is, you were about to have a DrPH, you were about to have a doctoral degree in this. I don't know what your plans are exactly, if you're going to go back and work in this space in India. So you or someone like you, and what is the role of whether it be academia or whether it be you know, whether it be quasi-governmental sort of research institutions? I mean, what is the role of sort of academic type research in moving this work forward in India and elsewhere?
Thank you. Thank you, Peter. I think before I answer these 3 questions, you talked about bringing in some additional variables to the analysis. Fixed effects regression was really a powerful way to demonstrate some of our findings. We also thought in between to bring in more factors. Maybe we will have a follow-up on that. For example, you know, the Swachh Bharat Abhiyan, which was like a very intensive effort by the government of India to improve the sanitation facilities, reduce qualification. So it started at a particular time point. So we can see like what has happened after that. So it's possible to model to see the effect of that. But again, that's a problem that it's applied across the country. So there is a challenge in doing that. But then we also have the change of governments, the state level, changing the policies. All right. So what is its impact? Which is like, again, we can have, you know, it's a time varying factor, so we can model it into the model. So we have that follow some of those follow plan, at least to see some of the states what has happened with this political and you know, governance changes. Second one on the question on the state level institutional mechanisms. all the states have like very different levels of strength and capacity in terms of institutions and technical expertise people available. So, for example, some of the states may be able to build some of this existing infrastructure and develop that research capacity faster. But again, there is always a challenge that at the highest level of decision making, not just at the political, but at the highest level of administrative decision making, the perception of the people who are at that positions matter a lot. Unfortunately, that's how it happens everywhere. So now the problem is, for example, even in a state like Kerala, which had the first state level action plan, we didn't have a pharmaceutical expert or a public health expertise in the committee that was supposed to decide on the action plan. So it reflects also on the document that we reviewed, So I think that there's no dearth of capacity of such people in states like Kerala and Tamil Nadu. It's a matter of understanding the need. I find a positive thing here, like the WHO country office has been very instrumental in pushing this action plan and also pushing in other states. I understand there's only one person who is actually in the whole country office who is supporting the country in this matters. But I think that is something which can be expanded, given the expertise and experience of India in managing tuberculosis, which has a major challenge in antimicrobial resistance and a major challenge in appropriate and inappropriate use of antibiotics. So I think there's a lot of lessons for the overall antibiotic regulation from what we did with the TB antibiotic market. So that's an important learning that we can use for expanding about this. At the national level, Indian Council for Medical Research, they have specialized institutions, including some new institutions which work on different areas of diseases, different research portfolios. I have not come across much except setting up a national level system of collecting data from some of the laboratories in terms of antimicrobial data. So ICMR should have a focus renewed on including antimicrobial consumption as well in the whole antimicrobial resistance work that they are leading. We also have institutions like React Asia, which is like working in different countries and continents, including in Asia. I know that they are doing a lot of small pilots. They don't call it pilots, so it's like interventions from their side to see like what is working and what is not working. They work with communities, they work with agricultural, farmers and things like that. So we have to consolidate some of these efforts, and we have to bring in more rigorous evaluations to see like what is working and what is not. I think that's something which I again answer the third question. Like I'm talking to these people. I'm talking to some of the people who are already in this call today, who have come up with some at the individual level, some of those plans and tools, which I feel like as a clinician, I always have this feeling that we should work at the policy and the program level, which is very, very important. At the same time, we should take into confidence the actual clinicians who are prescribing. Because we have seen the plus and minus of within the TB control program when we push them to work on the dots, alternate their regime, when they were hesitant to do that. So they were forced to use the private sector medicines which were not given everyday medications. So you have to have them in our in our discussions. We have to have solutions for them in the daily clinical practice, and we have to have large scale program and policy solutions with that. I'm discussing with these React Asia, some of my colleagues, and also with some of those people who are already in this call today, like with their trying to see like what we can do to test some of those solutions they think they work. I think this is which I will try to follow.
That's exciting to hear. Great. Do you have another follow-up question now?
One thing to ask, which we discussed, which I would think is really interesting to bring into our discussion, is the fact that governments have actually a lot of tools available to make data available. So you made a comment in your discussion, maybe you can help us understand and elaborate, because I think it's an important point coming back to what Sandra said about the instruments and tools available that other countries have used. So in your discussion, you talk about governments in other countries have mandated specific institutions to make their data on antibiotic consumption available. So they have to report to the government, which helps the government collect the information. No? Can you expand a bit more on what countries were you thinking of making that reference? What countries do we have that could guide us in that single model, how governments should set up policy tools or specific policies mandating reporting of antibiotic consumption?
Yeah, so I think it's very important to recognize that the current existing regulatory framework is itself a bottleneck in implementing and copying some of the mechanisms that we have in some other countries. For example, if needed, a state government can ask manufacturers or distributors to share the data with them. That's an ad hoc arrangement. But now we have like in other countries, like accreditation system for hospitals, which also some of our stakeholders in interviews mentioned. Why is government not using those facilities and tools to get this data? We are ready to do that, share that. But then that is something which is like, needs a political will to do that. So I think it's not just the availability of data, but it's also the will to have the data. Like, for example, we have FTC asking companies, mandating it, not just at the research or clinical research phase, even later to share the data. We do not have that system in place. In the beginning, it was just like some of the drug controllers go randomly and pick up sample and test it and say, oh, this is banned, this is not banned. It has progressed from that level, but still there is no GMP, there is good manufacturing practices. It's not mandatory to follow any of this. Even if there's some loopholes in this, they can easily circumvent those decisions. So I think closing some of those loopholes, implementing the good manufacturing practices in place. For example, I was just telling our colleague the other day, if you go to one company manufacturing a particular product in India, they will have at least 2 sites of manufacturing. One manufacture the same product, same branding for the Indian market. The other goes to other countries. So the generic drugs that we get in the US from Indian manufacturer come from one particular factory, whereas the same drug that goes to the Indian market comes from another particular factory. So there's a lot of issues. There are ways to actually implement the GMPs in place, which actually will help to have better control of data and accurate data. That's one thing which I would suggest. Second thing, we have the Clinical Establishment Act, which mandates licensing of hospitals, which actually includes a clause to collect data and share data. It has happened during COVID. It can happen even in non-COVID time.
Thank you very much.
Okay, great. So let me check back in with Sandra. Do you have any follow-up?
My other question I have is to Veronica's EU comparison. I don't understand enough about the political and administrative independence of Indian states to say how much EU comparison. Can you just educate me on that?
Yeah, it's interesting. So as I mentioned in one of my first slides, health is a state subject in India. So the state has literally all the rights to decide what to do in terms of health. So only few things that actually with the government, central government, the national government is about medical education regulations. Some of the large scale policies related to import and export of drugs. And also the SEDASCO, the central regulator, has the ultimate power to decide a new molecule to be approved or not. So if I have a new, say, amoxicillin, when it comes to market, it has to be approved by the central government. But once it is approved, you can have different formulations of amoxicillin. You can have formulations with any other molecules. You have different strengths. It all can be done by the state government. And state government, most of the state governments have very little capacity and expertise and human resources to do that. That's a challenge. And but again, once it is approved in one state, it can be solved anywhere in the country. So
Right, it's a person. No, I understand. Yeah.
Shaffi, any other questions from your side? Should be muted. I think we can move to.
Well, I have no questions, and I'm not much.
Okay.
No questions.
Great. So we'll close the committee-led part of the discussion and now open it up to questions from anyone else. Questions, comments. Shaffi's family, feel free to jump in and say anything. Oh, yes.
Not as always. This is an easy one, Shaffi. So no, this is a great presentation, and I think we got better listening to it for the second time. So this is really amazing. I think my first question was about the other way that India affects the world. I think we just talked about a bit about how because India is not just a model of a country that uses a lot of antibiotics, but it's also for a lot of countries the source of where other countries get their medication. So I think my main concern, how do the trends in India affect what happens in the rest of the countries? Sudan, for example, is one country that gets a lot of medication from India. I think you answered that a bit earlier, some of that, but if you can expand on that, that would be great. The other question I had was in terms of state control. So you said that a lot of states don't have the capacity or the resources maybe to design systems that are centralized. But what if the state itself, in a way, is opposed to centralized systems? So talking about Kerala, which you would you know way more than me about it, but it's a state that maybe has the resources, but it's a state in its health system is really against centralization, from my understanding of from some of the work we did together. For example, the People's Campaign, where they really tried to decentralize everything to the village level. So in such a state, would it even be possible to start with saying we need to centralize some of the healthcare systems? Is that something that's even doable?
Okay, so the two things. One is about exporting the drugs. So India is actually providing most of the drugs for major UN agencies and other organizations, like for example MSF. So that's when I come to know about these two factory settings. But then that is something, I think there's a quality check by these agencies, which actually helps to prevent some of those inappropriate combinations coming outside. Second thing, for the state level infrastructure, state level.
I'm really sorry. Not just the UN agencies, but they also have some bilateral agreements. Do they also stick with the UN checklist for those bilateral agreements?
Yes. So they go with the WHO list of essential medicines, and also the countries which export, they import, they decide what to import. It depends a lot on the capacities, but as far as I know, agencies who actually facilitate some of these processes, they really know this issue in India, so they are careful about, and the essential list and the medicines that are required by those countries will decide what to buy. So yeah, it's largely an Indian market. So now coming to state level regulations and the restrictions, of course, we are not talking about definitely these are like hot discussions back in India, like the standard state relationship. So it's not about health systems responsibilities being shared, but it's more of a higher level regulatory function with real technical capacity. At least the state level should have those capacity to do that at the state level or regional level. Central government, the national government should have facilities to support the different groups of states to do that. I think even the national level, there is an issue of capacity. You cannot have with a very few people to do all these things for such a large market like India. So I think it's not an easy task, but we have to start at one point. One thing that everyone put on table, and even the recent discussions that I'm following up, is that we need to have some sort of a better central regulation with obviously inputs from the states. And I don't see that the state governments really have any specific interest in not allowing this, except that it's a big source of tax revenue for some of those states, because they allow a lot of companies to run in the states. And then major chunk of their income, the GDP or the tax revenue is basically from some of these companies. That's all this is.
Okay.
So any questions?
Can I?
Yes.
Well, it's admirably outstanding work. Congratulations, Shaffi. My question is not on any limitations of your dissertation, but it's largely, I mean, you made a comparison in the second paper between states. And in your problematization, you mentioned the issue of structural adjustment program. And that is largely from the 90s and of course 2000. Do you think there is a difference before the structural adjustment and after the structural adjustment. I mean, because you did in a given period of time. That's why I'm asking this question.
Thank you. Thank you, Professor Nair, for asking this. I think we, one thing that we are planning with Shakti is to go back a few more years behind, not just from 2011, but at least we have data from the late 90s. So we have to see like what has happened over a larger period of years. But then to really look into the comparing between the period of structural reform before and after, I think we have to explore further, like what sort of data do we have. Again, with this large scale opening of the market, we found a large number of companies coming up and increase in the number of production units. So I'm afraid we may or we may not have that much of data to have a comparison before that period, but at least some look into the combinations approved or included in the essential list of medicines. Some of those things can be worked out. But again, I think there will be some limitation with exploring data beyond that level. I'm not so sure. Thank you.
Other questions?
Shaffi, any of the family members are connected?
Yeah, I think there should be my wife. I saw her.
They are there.
I didn't see her. I saw her name.
They are very technical online.
I think she just put that in online and went somewhere else.
No, I got off.
Yeah, I don't think there are.
They're happy. We're welcoming any of their comments if they want to leave comments as well.
Just say I don't think everyone. Sorry, you want to make any comment? Or Jennifer, Arun?
Maybe she can give us a clinician's perspective on whether.
Dr. Shaffi. Yeah.
Hello?
Yeah. Can you hear me?
Yes.
Yeah, I'm keeping my video off because of the slow bandwidth. Sorry, Dr. Shaffi.
This is Sudeep, right?
Yeah, this is Sudeep. Yeah.
Okay. That's my English actually. Please go ahead.
Yeah, it's a great piece of research. I understand, Dr. Shaffi, and I in fact, it is very, effortful job to get the data from, that on this diverse disciplines in pharmaceutical and other sectors. So my simple, I think, I'm sure you would have put some effort in your detailed dissertation, but I couldn't see any slides on that. Was there any effort to match your descriptive analysis with the HRH, human resource for health, across different states? Because that matters a lot, because as you indicated, health is a state subject here. Was there any effort on that?
Okay, Sudeep, thanks for asking this important question. So in our third paper, when we try to see like what it is to do with, in terms of the factors affecting antibiotic use, I think this is something very, very important. The human resource component, the doctors who prescribe the medicines and pharmacists who may dispense the medicines, qualified pharmacists. When we try to figure out the final set of variables, we didn't find human resource as a major factor because of the fact that we use this the fixed effect regression. We assume that at the state level, there may not be a large change in the number of, say, doctors availability over the last 10 years, the time period that we analyzed. We may be wrong in that. So with the model that we did, that confounding effect of human resources got adjusted with the panel data structure that we used in this analysis in the third paper. So we actually controlled for any change in the human resource capacity at the state level. Of course, we accounted, but the method accounted for the differences between the states in terms of human resource capacity. So that is actually adjusted in our model. When we finally see the model, it is actually taken into consideration.
Okay, thank you. Thank you. Thank you, and all the best, Dr. Shaffi, for that. Yeah.
Thanks.
Great. So no more questions or comments. Then the committee is going to exit the room, I think. Everyone else, please stay. We're going to go deliberate for a little bit and then we'll come back. Shakti, I think a separate room will be, a breakout room will be set up for you so that you can join us as we move to another physical location here. But everyone else, please don't sign off if you're on Zoom. Please stay.
Also, I don't see Shakti.
He hasn't joined yet. So.
I'm sure he joined us.
Tom to join.
Shaffi.
Yep. Shakti? Yeah,
Yeah, I'm around.
is there?
Yeah, Shakti, we need you to join the
He
breakout room.
needs to join the breakout room.
Okay.
Can you do that? If you do that, I'll see you on my computer.
Yeah.
He's on.
There you
Okay,
go.
very good. Stay with us.
You know, we fought against the technical difficulties.
How much we do? I don't see many people here. I'm sorry, sir. Oh, 70. I'm saying this. Where after this 75?
Oh, yeah. those are the
I thought it was
points.
37 people. I was like, what?
Oh, yeah.
No, but
37
at a
columns.
point, there were like 34 people.
Yeah, I mean,
I think they,
Barco was there.
yeah, I think they have to leave for.
Yeah, it's long.
Just read the comments now. Yeah.
Not the
Oh,
every part.
echo, no.
That was sound.
Read the congratulations.
Start really where they start congratulating.
Jerry really doesn't care about this.
Yeah, see?
Jean was there.
Yeah,
Oh,
Jay,
Where's
yeah.
Trish?
Trish is on.
Trish is on vacation.
Yeah, she's
Oh,
on main, yeah.
Yeah.
She's away.
Yeah, she told me that she may not have internet access. It's okay. Recording.
It's recorded.
Wasn't you mute your phone?
yeah.
Hey. No, building. That's not how it works.
All right, turn it off. All right, now I should be able to hear you.
Can you hear me? Shaffi, can you? Well, I can unmute it.
It is unmuted now.
Shaffi, you join. You can.
Shaffi is back, yeah.
Oh, he's back.
Yeah.
Yeah, I should.
Oh, you found this here, Shaffi, look.
Yeah, that's my father-in-law, my daughter. Yes.
Great, can everyone hear me?
Yeah.
The folks here? Your ship is not muted.
I think you.
Shaffi, you're muted.
Yeah, they.
Great.
Yeah.
So in our discussions, I think the committee has agreed that this is just an incredible piece of work that you've done. You far exceeded everyone's expectations and have really generated a dissertation that is, a top example of a DrPH dissertation at this university. And so we're very honored to be able to confirm that you have successfully defended your dissertation and introduce you as you already are a doctor, but now you are a double doctor. Congratulations.
Oh, you know. You get to take one of those. And the DrPH committee just like to give you.
Congratulations, Shaffi, congratulations. An outstanding work.
Congrats.
Thank you.
Congratulations. Congrats, Shaffi.
Thank you.
These things.
Oh,
Yeah,
yes.
we take a photograph. So I take it.
Congratulations, Shaffi.
Thank you, Shakti. Yeah.
Spread the seats around, please.
I could take a picture, she would think.
Yeah.
Great.
Thank you.
So, let me make so
Yeah. Then I can carry everything on tape and
no additional.
I can inform the librarian that.
Some surgical training.
Right.
Yeah, thank you. Thank you.
Right?
Still early.
Yeah.
It's late enough.
I think they're
Not
all.
much.
Yeah.
Yeah, I have take your cake and leave.
Take your cake and leave.
Right?
They can hear us,
Thank you.
They can hear us, right?
Yeah. Shaffi, hook you up one.
Yeah.
I think that might be it.
Cheers.
Congratulations.
Cheers. Congrats.
Congratulations, congratulations, Shaffi.
And Shakti.
Awesome.
Can have a photo.
Yeah.
Or for the photo?
Excellent.